Welcome, everybody. Thank you so much for attending today's seminar. Today, we're very fortunate to have with us Emma Pierson. Emma is a senior researcher at Microsoft Research New England and is an incoming assistant professor of computer science at Cornell Tech. She develops data science and machine learning methods to study inequality and healthcare. Her work has been recognized by a Rhodes Scholarship, a Hertz Fellowship, a Rising Star in EECS, and a Forbes 30 under 30 in science. She's also written for the New York Times, FiveThirtyEight, The Atlantic, The Washington Post, Wired, and numerous other publications. Emma, on behalf of everybody here, thank you so much for making time out of your busy schedule to come here and to give a talk in this Zoom room. And we look forward to seeing and learning more about your research.
Sure. Thank you so much for the invitation. It's a pleasure to be here. Happy Friday, everyone. So today I'm going to be talking about data science for social equality. And to frame this talk, I'm going to make a point which I think does not need to be belabored to this room, the fact that our society remains profoundly unequal, right? And you see this along virtually every demographic dimension, from socioeconomic status to gender to race, etc. And I suspect you already know this, so I won't belabor this point. Slightly less well known is the fact that computer scientists can and have made this worse. We see this in language processing. When we try to train language algorithms on text written by humans, the algorithms learn undesirable stereotypes from the text, like man is to computer programmer as woman is to homemaker. This isn't surprising, since algorithms pick up on patterns of all kinds. But it's a big problem if you then use these algorithms to, for example, screen resumes, and they rank women's resumes as less good for computer science jobs. We see this in computer vision. This is a picture of Joy Buolamwini, an MIT researcher who realized she had to wear a white mask for an algorithm to detect her face. In subsequent work with Timnit Gebru, she's shown that algorithms are more likely to misclassify the gender of darker-skinned women. We see this in healthcare when a widely used algorithm used to predict health risks exhibits racial bias. Black patients with a given risk score are sicker than white patients with the same risk score. This bias occurs because the algorithm is trained to predict cost as a proxy for health, and Black patients who have unequal access to care have less money spent on them than equivalently sick white patients. In general, so many similar examples of this phenomenon have cropped up in recent years that multiple books have been written on it. The overall message is quite simple. Far from being a panacea to social inequity, algorithms can actually exacerbate it. This talk, though, pursues a more optimistic counterpoint, that data science and machine learning, properly applied, can also reduce inequality. Given our role in increasing it, this represents not just an opportunity, but an obligation. Specifically, today I'm going to be telling you 3 stories about how we can use data science and machine learning to improve healthcare for underserved populations. I'll start by telling you about how we can use them to study pain, then I'll talk about women's cycles, and I'll close by discussing a topic I'm imagining is on all of our minds, COVID. So let's jump right into it. Let's talk about disparities in pain. This is joint work with David Cutler, Yuri Leskovic, Sunil Mullainathan, and Ziad Obermeyer. And you can find the paper published a couple of months ago in Nature Medicine. So a general fact about pain is that disadvantaged groups experience more of it. You see this for socioeconomically disadvantaged groups across a variety of types of pain, multiple continents, multiple sample types, etc. It's quite a robust finding, and you see it in racially disadvantaged groups as well. And this is also true in the condition I'll be telling you about today, knee osteoarthritis, which is one of the most common causes of disabling pain in older adults. So odds are very good that multiple people listening to this talk will develop it if they haven't done so already. Mechanically, what's going on is with the wear and tear of time, the bones in the knee get closer together, the cartilage erodes, the bones grind together. This causes a lot of pain, very common cause of disabling pain. And in this condition, as in other medical conditions, disadvantaged racial and socioeconomic groups have worse pain. Now you might say, oh, maybe they just have worse osteoarthritis. But here's the interesting thing. These groups have worse pain even when we control for how severe the doctor thinks their disease is. So I want to make that statement numerically precise for you, but for the numbers to make sense, you have to understand how we measure severity and how we measure pain in osteoarthritis. So now I'm going to tell you that. So the way severity is traditionally measured in knee osteoarthritis is that a doctor will look at an x-ray of the patient's knee and will assess it on various clinical features of osteoarthritis, like whether there are bone spurs, osteophytes, how much the joint space is reduced, etc. And they'll take those clinical features and they'll summarize them in a single number called Kellgren-Lawrence grade, which I'll call KLG. This is a categorical scale ranging from 0 to 4, where higher scores indicate worse severity. But basically, it's based on a doctor looking at an x-ray of the knee. How do we assess pain? Well, you ask the patient a bunch of questions like how much pain do you feel when bending your knee, when going up the stairs, et cetera, and then the results of that multi-item survey are aggregated into a single number called KOOS pain score. So it's based on the patient's self-report. The data we'll be talking about today comes from the Osteoarthritis Initiative, which is a very widely used, publicly available study of people who either have osteoarthritis or are at high risk for developing it. And we're going to be comparing pain by 3 binary groupings. We'll be comparing Black to non-Black patients, lower to higher income patients, and lower to higher education patients. And I should mention that almost all the non-Black patients in this data set are white. So what do I mean when I say disadvantaged patients have greater pain? So here what I'm showing you is a vertical histogram with pain on the vertical axis, and basically lower scores, worse pain. This is this KOOS scale I was telling you about before. And you can see that there's a striking visual difference in the histograms for Black patients and non-Black patients. If you want to summarize the size of that difference, standard way to do so is just take a simple difference in means, and that's about 10.6 points on the KOOS scale, 2/3 of a standard deviation. So it's a big gap. You can see it by eye. And you can do the same thing for income and education, and the gaps are somewhat smaller, but they're still statistically significant and substantively large. So what happens when we control for severity, for that KLG score I was telling you about before? Well, the results of this analysis are shown in the graph at right. You can see KLG is now on the x-axis, that's severity, right? And the important point here is that the orange and blue lines are still not on top of each other. Even controlling for severity, this gap in pain remains. If you want to summarize the size of that gap, a standard way to do so is just with a simple regression of pain on race and KLG. And then the pain gap is the race coefficient when you control for that KLG score. And you can see that for race, for example, the pain gap shrinks from 10.6 points to 9.7 points, which really isn't a very big decrease, right? It's just a 9% decrease. Results for income and education are similar. The overall point being that controlling for this severity score for KLG doesn't do that much to narrow the pain gap. This isn't our finding, by the way. It's not just in our data set. Other studies find this as well. The goal of our paper is to explain why this is. Why does a pain gap remain even when controlling for severity? In particular, we're going to try and distinguish between 2 theories. The first theory, called the outside their knees theory, postulates that there are non-knee related factors which are causing disadvantaged patients to experience greater pain even when their knee disease is no more severe. So what might such factors be? Things like higher life stress, less access to pain medication, et cetera, et cetera. But the commonality here is that whatever these things are, they can't be seen in a knee x-ray, and that's why controlling for the doctor's assessment of the knee x-ray doesn't do that much to narrow the pain gap. But there's a second possibility, right? And we call this the in their knees theory. Namely, that there are pain-related ailments in the knee x-ray, which KLG isn't capturing. And if we could capture these things, we'd be able to explain more of the pain gap. So under the first hypothesis, there's nothing extra to be seen in the knee x-ray that's being missed by that clinical score. And under the second hypothesis, there is something. There is signal being left on the table. So why is the second hypothesis even plausible? Like, is this just some crazy thing we dreamed up? Well, here are 2 reasons. The first is that we don't understand pain all that well. This is true in general. It's also true in osteoarthritis in particular. KLG doesn't explain that much of the variance in pain. And a possible reason for this is that KLG was developed decades ago in heavily white British populations. So it's plausible that it doesn't capture all the environmental and occupational features that are relevant to pain in modern and more diverse populations who may live and work very differently and thereby suffer different risk factors. So we're going to try to assess whether there are overlooked physical features in the knee which would explain the higher pain levels in disadvantaged groups. This isn't just an academically interesting question, it's also a question with clinical implications. And the reason is that whether you get knee surgery depends on whether the source of your pain is in your knee. If you go to the doctor in a lot of pain and she looks at your knee and she says, I'm sorry, I can't see anything wrong with this, she's unlikely to operate on an apparently healthy knee. She's more likely to prescribe non-specific therapies like opioids or other painkillers. If, on the other hand, you go to the doctor in a lot of pain and she says, aha, I know exactly what's wrong with you, very severe osteophytes, KLG4, then it's more likely under clinical guidelines that you'll get surgical interventions like arthroplasty, etc. Consequently, if we are missing true sources of pain within the knee in disadvantaged groups, they may be under-referred for surgery. Okay, so we're going to look for this extra signal. How are we going to do it? Well, we're going to train a deep learning algorithm, a convolutional neural network, to search for additional signal in the knee x-ray, which would explain the higher pain levels in disadvantaged groups. And we're not just like using deep learning because like it's a cool way to get published here. We're using it because empirically it's been by far the most successful method for extracting signal from medical images and other types of images over the past few years. Okay, so how do you actually train the model to extract signal? Well, the standard approach to extracting signal from a medical image is to train the model to replicate a doctor's clinical judgment, which here would mean take the x-ray, predict KLG. And you know, this is fine. Multiple papers have been written on exactly this task, on exactly this data set, and clearly it's useful to do sometimes. But the problem here is that the whole hypothesis is that KLG might not capture all the pain-relevant features. And consequently, we don't want to train a model just to replicate it. We don't want to set a ceiling of clinical knowledge when by hypothesis that knowledge might be biased or incomplete. Instead, we're going to train the model to learn from the patient directly by predicting Coos pain score. So to be very concrete, the input is an x-ray of both knees, and the output is a knee-specific pain prediction, which we term ALGP for algorithmic severity measure. And if controlling for the algorithmic severity measure ALGP narrows the pain gap more than controlling for the clinician severity measure KLG, it implies that the clinician severity score overlooks knee features which could help explain disadvantaged patients' higher pain levels. So before I show you the results, are there any questions about that basic methodology?
How is the algorithmic severity, the thing that you just mentioned in the last slide, how is that different from the Coos score?
Because that's the prediction of the Coos score. So it's how much of the Coos score can be predicted from the knee scale itself.
So just to understand the prediction problem, the input is an knee X-ray, and the output that you're trying to predict is the Coos score.
Exactly, that's the target, right? So you can think of ALGP as sort of y hat. It's our best prediction. Mm-hmm. Other questions? Okay. So our first result is that the algorithm does, in fact, find additional signal for pain in the knee x-ray. We find that ALGP predicts the pain score better than the clinician severity score KLG. The R-squared is higher. The difference is statistically significant. The results are robust across other predictive measures like RMSE, et cetera. But of course, those R-squares really aren't that high, and that isn't the central focus of the investigation anyway. The main question is, when we control for the algorithmic severity score ALGP, does it reduce the pain gap? And it turns out that the answer to that second and more important question is also yes. So here, the first numerical column is just what I showed you before. It says controlling for the clinician severity score KLG doesn't do much to narrow that pain gap. But the second numerical column is new. It says how much smaller does that pain gap get when we control instead for ALGP? And you can see that it's considerably more. The final column gives the ratio of the first two columns. So you can see for race, for example, the algorithm explains 43% of the pain gap, whereas KLG explains only 9%, a ratio of 4.7. The overall implication of this table is that there is overlooked signal in the knee X-ray, which helps explain disadvantaged patients' higher pain. Okay, so I'm not going to talk in great detail about the robustness checks we performed here, but I will summarize them briefly for you. This is sort of a slide that summarizes some of the things we worried about, and I'm happy to chat more about any of these particular ones at the end if people are interested. Another result I want to mention is how dataset diversity contributes to model performance. So why do we care about this question? Well, there's been a lot of concern in the medical literature over, if you train your algorithms only on white people or you train them only on men, then it's plausible that you won't learn all the things that are relevant to other populations. This is not just a concern in the machine learning medical literature, it's the concern of the medical literature more broadly, given sort of the historical way medical data sets have been collected. So the experiment we do is to try and understand whether that is in fact the case in our data. We compare training the model under two conditions. on a non-diverse train set, from which we've removed all the Black patients, and training it on a diverse train set, from which we've removed the same number of non-Black patients. So the size of the train set remains constant in both cases. The only thing we've altered is the racial diversity of the data set. And what we find is, while both models outperform KLG, the clinician score, using a diverse train set further boosts the performance of the model. We get better predictive performance for pain, we get a better reduction in the pain gap. And we see similar results for income and education as well. The overall implication being that, yes, this is an empirical demonstration of the fact that dataset diversity matters. I also want to speak about the clinical implications of these results. So as I mentioned, one of the reasons we care about these severity scores is that they influence the allocation of surgery. So in order to assess the magnitude of this effect, we replicate a previous study where we give knee surgery to patients who satisfy two criteria. They have high pain and they have severe disease. But we try measuring severity in two different ways, using the clinician severity score, KLG, and using the algorithm severity score, ALGP. And what we find is that because ALGP gives disadvantaged patients higher severity scores, it is also more likely to refer them for surgery. So the overall implication being that using algorithmic predictions as a decision aid might potentially be able to sort of reduce these disparities in access to surgery. Okay, so to summarize this part of the talk, we trained a deep learning algorithm to predict pain from knee x-rays and showed that it could find overlooked signal, which would help explain disadvantaged patients' higher pain. A clinical implication is that disadvantaged patients may be under-referred for surgery. To put this within broader context of work in algorithmic fairness, there's been a lot of previous work, some of which I just mentioned, about how machine learning methods can potentially increase disparities in medicine. And this is essential and invaluable work. This stands as a counterpoint, showing that machine learning methods can also reduce disparities by detecting signal that humans miss. And key to our results here, key to reducing rather than increasing disparities, were first, we chose a prediction task that didn't merely seek to replicate potentially biased or incomplete clinical knowledge. And second, we trained the model on a diverse data set, and we show empirically that that contributes to our results. Any questions about this before I go on to the next part of the talk? Or also, if you want to think about it more, happy to take questions at the end.
I think that'll probably be better.
Okay, I'll go on. Okay, so let's talk about women's cycles. This is joint work with Tim Althoff, Daniel Thomas, Paula Hillard, and Uriel Leskovic. And it came out, I guess, a couple weeks ago, months ago or something in Nature Human Behavior. Okay, so we know that cycles are fundamental to human health, right? You have like the daily cycle where people, sleep at night, circadian rhythms, etc. You have the weekly cycle where perhaps you sleep in on the weekends or you go out on Fridays, or like you used to go out on Fridays back when the world was normal. You have the seasonal cycle, like maybe you exercise more in the summer, you sleep more in the winter or something like this. And then you, of course, you have the menstrual cycle. And the menstrual cycle is very important. It's implicated in a whole range of health conditions, medical conditions, everything from cancer to schizophrenia to pregnancy. Unfortunately, stigma and lack of large-scale data have hampered study of the menstrual cycle. And you see this in medical data sets where basic data on the cycle is often lacking from multiple types of medical data. You see it in health tracking apps like Apple and Fitbit, who were slow to add menstrual cycle information and did so only in response to popular outcry. You see it when clinicians don't always consider this fundamental aspect of health, and you see it in a broader culture that stigmatizes discussion of this topic at all. And this is not some abstract ivory tower issue, right? This results in concrete harm to the health of half the global population. And to give two concrete examples of this, the girl on the left is required to stay in that tiny hut outside when she's on her period as a consequence of stigma associated with the cycle in Nepal. And it's not hard to see why this is potentially dangerous, right? Girls have been bitten by snakes, they've been sexually assaulted, they've died of smoke inhalation. The woman on the right is Noemi El-Haddad, a professor of biomedical data science at Columbia, who has suffered for much of her adult life with pain from endometriosis, a condition linked with the menstrual cycle, which is still poorly understood as a consequence. There is good news here, though, which is that women's health apps offer new potential for understanding and destigmatizing this fundamental aspect of women's health. Specifically, today I'll be telling you about the Clue Women's Health app, which is used by millions of women across more than 100 countries to track more than 100 features every day, everything from mood to pain to pregnancy, and crucially for our purposes, when their menstrual cycle is starting. So to give you a sense of the kind of data that people can log with this app, and importantly, by the way, this is just simulated data, it's illustrative, so it'll give you a sense of what people can log, but it's not real data for user privacy reasons. This is just data that can be logged by a single person. So here the x-axis is time, the y-axis is what they're logging, and you can see, for example, people can log, period symptoms, so when their cycle is starting. You can see they can log resting heart rate or weight, so like continuous features, basically. And then you can see they can also log sort of categorical features of mood and behavior, like sexual behavior or mental state, etc. So we're going to use this data set to provide the first decomposition of female mood, behavior, and vital signs into 4 simultaneous cycles, those 4 cycles I was telling you about before. And by doing that, we're going to improve understanding of the menstrual cycle and other cycles in women's health. So our data set consists of millions of women, hundreds of millions of observations across more than 100 countries, and we're going to be studying cycles in 15 dimensions of mood, behavior, and vital signs. So things like happy versus sad mood or resting heart rate. So how do previous studies look at cycles? Well, basically what they often do is they take a population average. So this is a graph reproduced from a science paper that came out about 10 years ago. And they're studying happiness as inferred from Twitter data. So, take the measure with a grain of salt because Twitter is weird, of course. But happiness is plotted on the y-axis, and on the x-axis, they're plotting time. And you can see sort of these daily cycles and sort of weekly variation as well. And basically the way they're doing this is if they want the value at like 3 p.m. on a Thursday, they take a population average of all people at 3 p.m. on a Thursday. Similarly, this shows a different study, longer time periods, still looking at Twitter data, and you can see that sort of weekly cycles emerge and sort of holiday outliers emerge, but the methodology is the same. You're sort of taking a population average. And we can do this in our data as well. So this is a graph we actually made, and it's looking at our data, and it's plotting happy, sad mood as reported by the user. And you can see that things emerge. This is clearly a valuable methodology that reveals important aspects of human mood and behavior, right? So like that high frequency fluctuation, that's the weekly cycle. You can also see holiday outliers, like the green dots are Christmas. The purple dot is the day after the 2016 US election, which, given that this is a predominantly female, predominantly young, and predominantly international population, is, roughly what you would expect. So this is clearly useful, right? But the problem is that taking a population average in this way will make the menstrual cycle invisible. Why is this? Because cycles aren't synchronized across all people, right? Unlike with the daily, weekly, seasonal cycles, right? So if you average together everyone on January 3rd, they're all going to be at different phases in their cycle, and this is going to get totally washed out. And it turns out that this is quite important, right? So I'll tell you how we get the red line in a moment, but it shows the counterfactual, where we could actually observe this menstrual effect, and you could see that there would be considerably more cyclic variation. In particular, the cycle amplitude is comparable to the Christmas effect, somewhat smaller than the US election effect. So this is an important thing. So
Emma, could you explain what the red line, what is that red line across the entire population? Is this for...
Right. That's a great, yeah. So I'll tell you how we actually get that in like the next 2 slides, but basically it's plotting the counterfactual where we could observe that menstrual cyclic variation. Like if we could just basically take the magnitude of the average menstrual variation, and we just sort of added it to the overall signal, that's what you would see. So let's talk about how we actually get that though. Okay, so how are we actually going to get the red line, basically? Well, we're going to decompose people's mood, behavior, and vital signs into 4 cycles, and we're going to do this using linear regression, multivariate linear regression. Specifically, we're going to take each observation, so mood for one person at one time point, and we're going to regress it on categorical variables, which encode the 4 cycles. We're going to have one categorical variable for hour of day, like 3 p.m., one for day of week, like Sunday, one for month of year, like December or November, and one for day of menstrual cycle, like 3 days after the period starts. And then when we plot the regression coefficients, we'll find that they capture the magnitude of the cycles. So that's a little abstract. Let's show a concrete example for mood. So this is, now you see the red line. Basically, I just took that thing and I added it to the original signal. So what I'm plotting here is the regression coefficients corresponding to the 4 cycles. So from left, it's the menstrual, daily, weekly, and seasonal cycles. And you can see from this graph, for example, that like positive mood, decreases prior to the period start. So when the period begins, it goes down late at night. People are sort of happier on the weekends, and they get sort of sad when school starts again. Not that we don't all love school, we love school. So clearly this is revealing sort of important fluctuations over the cycles, but it's also showing you that the menstrual cycle happiness amplitude, so basically the amplitude of the menstrual happiness cycle is in fact the largest of these 4 cycles. The overall implication being, this is why menstrual data is important. Without it, the largest cycle for this dimension just vanishes. And, I just showed you happy, sad, mood, but we do the same analysis for 14 other dimensions of mood, behavior, and vital signs. And we find that the menstrual cycle is the largest cycle for many of them. For example, it's quite prominent for all 3 vital signs. Another thing we're able to do, due to the large size of our data set, is study how the menstrual cycle varies across cultures. And one thing we find is that it's quite directionally consistent across cultures. So people sort of consistently get sadder prior to their period beginning. And this is interesting because a lot of previous studies have been sort of small scale, confined to one country. And as a consequence, it's hard to know how much their conclusions generalize and how much of them are sort of culturally specific to, like, small liberal arts colleges in northern, whatever, New York or whatever. Okay, so I want to be very clear about what we're not saying with these results. We're not saying that women are more volatile. And there are a couple simple reasons this is the case. So first, our analysis doesn't make this comparison at all, right? We make no comparison across genders or sexes. And indeed, previous research does not find sex differences in volatility. There's this great paper entitled "Female Rats Are Not More Variable Than Male Rats" by an author who is clearly sort of annoyed by this whole sexist trope. So why doesn't it find sex differences in volatility? Well, one reason is that there are male hormone cycles as well. They're just less focused on for various reasons in the popular literature. And I think it'd be very interesting to study male cycles too, although our data set, of course, did not allow that. The other reason is that cycles are not the only source of volatility or variability between people. For example, if your favorite sports team wins or loses, or your uncle dies, or you get a COVID vaccine or something like this, right? These are all very important sources of variability, which are not included in our analysis. We also don't consider between individual variability at all. The fact that some people are happy, some people are sad. So if someone weighs, 20 pounds less than the population average, that is not because they're on their period in all probability, right? It's probably because of between individual variation or other factors which affect. So overall, our analysis does not imply that the menstrual cycle is the only source of variation or even a large source of variation. It simply implies that it's an important cycle, certainly as important as the sort of more widely studied and less stigmatized daily, weekly, and seasonal cycles. So to summarize, stigma and lack of large-scale data have hampered study of the menstrual cycle. And this is bad because it's actually a primary contributor to cyclic human variation. The good news is that women's health data sets offer the unique potential for understanding it. I'll just mention briefly here that we actually wrote 3 papers on this topic using this data set with CLUE, who were great collaborators, one studying pregnancy and trying to predict pregnancy and fertility, and one sort of developing general methods for understanding human cycles. So yeah, I think there's a lot of potential here from this new data source. Any questions before I go on to the final part of the talk? Or again, happy to take questions at the end. Cool. Okay, I will go on. Okay, so let's talk about disparities in COVID. This is joint work led by the excellent Serena Chang at Stanford with Peng-Wei Ko, Jolene Jardine, Beth Redbird, David Grusky, and Yuri Leskovic. And it's a very interdisciplinary team. So we have an epidemiologist, we have a couple computer scientists, we have some sociologists. It's all over the place. And you can find the paper online, came out in Nature a couple months ago. I don't think it's paywalled, hopefully. Okay. So as you all know, viruses like COVID spread through human contact, right? That's why we're doing this remotely. Which is to say there's an underlying contact network that controls the spread of the virus. A simple epidemiological model would be that an infected person can infect anyone she comes into contact with. Those people then infect their contacts, and you get sort of the explosive spread of the virus across this network. Understandably, therefore, understanding what this network looks like is very important to modeling the spread of the virus. But of course, actually, as we were just discussing, it's very difficult to know what the human-to-human contact network looks like, right? It's hard to know who everyone comes into contact with. Consequently, current models, epidemiological models, have often made necessary simplifying assumptions about what these networks look like. For example, they might assume that anyone can infect anyone, so the network is fully connected. Or they might use a network which captures trends at a very high level, for example, an airline network connecting city to city, but doesn't tell you anything about movement within individual cities. Or they might use data from 2015 and just kind of hope that it describes movement in 2020. But it's plausible, right, that these simplifying assumptions might not be sufficient to deal with our current regime. And here are two reasons this is so. The first is that we're undergoing an incredibly dramatic change in human mobility, certainly the most dramatic in my lifetime, hopefully the most dramatic for the rest of my lifetime, right? And the second is that the kinds of policy questions that we care about often depend upon mobility in a very fine-grained way. So we might want to understand, for example, what happens if we reopen restaurants, but only to 75% capacity and only from 3 to 6 p.m. on alternate Sundays. Okay, that would be a weird policy, but you understand what I mean. Or we might want to understand fine-grained inequality in infections due to mobility patterns. So we might want to understand, why are rich neighborhoods in New York getting infected at lower rates than poor neighborhoods? And if we want to understand that, using something which just connects New York to Los Angeles, or which assumes that everyone has uniform mobility, that's clearly not going to be adequate to explain these patterns. So what we're going to try and do is estimate this network, and then we're going to put an epidemiological model on top of it and use it to understand things like reopening policies and inequality in infections. Okay, so what is this network? What are we actually trying to estimate? Our network is going to capture visits from neighborhoods to places. So neighborhoods here are census block groups, which are sort of small census areas where a couple hundred to a couple thousand people live. And places is going to be POIs, which stands for points of interest. And those are going to be like restaurants, grocery stores, churches, places people go when they're not at home. So our network is going to tell us about the number of hourly visits from a given neighborhood to a given place. So importantly, we're not tracking the movement of individual people, but we're still tracking it at quite a fine-grained way. So, okay, for those who like sort of more quantitative descriptions, basically at each hour, we want to infer how many people from a given neighborhood went to a given place. So you can think of this as sort of a list of hourly networks, or you can think of it as a giant 3D tensor cube, but that's the mathematical object we're going to seek to infer. How are we going to do this? Well, we're going to rely on data from a company called SafeGraph, which uses anonymized and aggregated location data from many cell phone applications. So basically their business model is, some apps track their users' location with consent. Those apps then pass their data onto SafeGraph. SafeGraph aggregates the data. And as part of sort of the COVID fighting effort, they've made the data available to academic teams and other sort of research organizations. The data set we're going to be looking at covers 10 of the largest US metropolitan statistical areas. You can think of that loosely like a city, although it's really the city and the surrounding area. We're going to be studying the movements of 98 million people. For computational tractability reasons, we'll model each MSA separately. So we're not going to consider like New York to LA travel. We're going to model New York and LA as separate systems. And we're going to be studying the first wave of infections in spring 2020. The reason for this is because that's the data that was available when we wrote the paper. Serena's since done a lot of work to update it on more recent data. Okay, so what data does SafeGraph actually give us? Well, first, for each POI, so each place, it tells us how big it is in physical feet, square feet of the restaurant or whatever. It tells us how long people tend to stay, and it tells us what type of business it is, like whether it's a restaurant or so on. And then it also tells us about visit patterns, the sort of flows of people between neighborhoods and places. At a fine-grained timescale, so like an hourly timescale, it tells us how many people leave each neighborhood and how many people go to each place. And then at a monthly timescale, it tells us about the actual sort of neighborhood to place network, the CBG to POI network. The problem is that we actually want that network on an hourly timescale. Okay, so how do we deal with this? Well, mathematically, basically what we have is the number of hourly people leaving each CBG, the number of hourly people going into each POI, and the monthly estimate of the actual network. So you can think of this as basically a network inference problem or a matrix inference problem, where we know the row sums of a matrix, the column sums of a matrix, and a noisy estimate of the matrix itself. And then we're going to try and estimate the matrix from that data. The matrix here represents the actual hourly network. Fortunately, there's an algorithm designed for exactly this setting called iterative proportional fitting, which we apply to infer the hourly matrix. Basically, IPF says, if you know the row sums of a matrix, the column sums of a matrix, and you have a noisy estimate of the matrix, then I will give you a matrix which is consistent with those row and column sums and subject to that constraint as similar as possible to the original noisy matrix. So we're going
one clarifying question. So the row sums, I'm assuming, is the hourly number of people who are going out from a neighborhood, right? And these are things that you get, and the rows and the column sums are things that you're getting from the data directly.
Yeah, exactly. Yeah, the orange things are things we get from the data.
What's the noisy estimate?
The noisy estimate is the monthly POI CBG matrix. And the reason it's noisy for each hour is because it's only a monthly estimate. If that
and
makes
why?
sense.
So can you not directly calculate if you know? I see, because you're not, because this data does not track individuals, so you can't track that of the people who left neighborhood in this particular hour, how many went to POI X.
Yeah, we just know like 50 people left this neighborhood, 10 people
Okay.
came into this restaurant, and on a monthly level, 504 people went from that neighborhood to this restaurant. Yeah, so yeah, that's a good question. No one ever asked a question on this slide, so thank you for actually asking that question. That was helpful. Okay, great. So, okay, fine. So in total, our networks encompass about 500,000 places, about 50,000 neighborhoods, and 5.4 billion hourly edges. Okay, so that's a little mathy and abstract. Let's be very concrete about what we're getting as output. So this shows you, I'll use as a running example Chicago. I'm just using that because it's representative and to kind of save space, but you can find all the graphs for every city in the paper. And on the left, I'm showing you two networks, two hourly networks. On the left, early March, on the right, early April. So this is sort of pre and post social distancing taking effect. The gray line here, the gray lines are sort of, the weight of them is illustrating the number of hourly visits. So you can see basically that the density of the gray lines drops a lot from the left to the right graph, indicating that mobility is decreasing. You can also see that most of the gray lines are vertical, so people tend to hang around their own neighborhoods. And we've made all the networks publicly available to, aid reproducibility and also sort of extensions of our work. You can download those online. Okay, so now we have a network, right? Hourly number of visits from neighborhoods to places. So now we have to put an epidemiological model on top of this network. So crash course in epidemiology, right? Many of you have probably heard of this model. It's been in the news a lot. There's something called an SEIR model. How does this work? Basically, it says people move through these 4 states: susceptible, exposed, infectious, removed. When a disease has not entered a population, everyone is in the susceptible state. They've never caught the disease. They can catch it. If they come into contact with someone who's infectious, they risk moving into the exposed state. They have the disease. They're not yet dangerous to others. It's sort of latent in them. Then after some period of time, they move into the infectious state, which is to say they have the disease, they can infect other people. And then finally, after a further period of time, they go into the removed state. They no longer have the disease. Maybe they've recovered, maybe they've died, but they can't catch it again. You have to move in this order through these 4 states. You can't go back from R to S. This is obviously a simplification of the real world, but it's a very widely used and interpretable epidemiological model. So what we do is at each hour of our simulation, we model the fraction of each neighborhood in each of these 4 states. So we might say, for example, in neighborhood 10 at hour 4, 96% of people are in the susceptible state, 3% of people are in the exposed state, 0.8% of people are in the infectious state, and 0.2% of people are in the removed state. Hopefully that adds up to 100. And then we just sort of, we model the evolution of the fractions of people in each state over time. So how do we actually do that? How do we model the transitions between the 4 states? So it turns out that the modeling of the last 2 transitions from E to I and I to R are not very interesting. We just assume that there's some sort of stochastic probability that the person goes on to the next state at each time point at a rate that is given from the prior literature. But that first transition is sort of the secret sauce of our model. This is the part that depends crucially on mobility. And this is quite intuitive, right? Whether you get exposed to the disease in the first place depends on whether you go out and whom you come into contact with. So specifically, we assume that new infections, those S to E transitions, occur in one of 2 ways: at CBGs or at POIs. We assume that and so those CBG infections are sort of capturing, you were at home, you didn't go out, but someone in your home was sick, and now you yourself are sick. The POI infections capture stuff like you went out to a restaurant and so unfortunately someone in the restaurant was sick and now you yourself are sick. So we assume that the CBG infection rate, the risk of getting infected at home, is just proportional to the fraction of your neighborhood which is infected. Neighborhoods are more dangerous if there are more sick people there. we assume the POI infection rate is similar, but a little tiny bit more complicated. Basically, your probability of getting infected at a POI is proportional to the fraction of the POI which is infected times a POI specific factor. And that POI specific factor is taking advantage of the metadata I told you about before, capturing things like bigger POIs are less dangerous, POIs where people stay longer are more dangerous. You can find the actual form of the equation in the paper. Okay, so in order to actually fit the model for each city has 3 free parameters, which scale the number of the rate of infections at CBGs, the rate of infections at POIs, and the initial conditions in the model. So how many people start infected on March 1. And basically what we do is we search across all those parameter settings, and we use the one which achieves the actual best fit in terms of RMSE to reported daily cases in that MSA. So that's how we sort of link back to real world COVID data. We can chat more about the specific details of model fitting if it's of interest, but basically, yeah, we try and choose the parameter setting which has the best fit to real world cases. Okay, so here's a movie showing you sort of what actually happens when you run this model forward. And this is in Chicago again. So from left, the graph on left is just showing you mobility over time. It starts on March 1. You can see that there's sort of a dramatic fall in mobility about 2 to 3 weeks into the simulation. This is when lockdown takes effect. The graph in the middle is showing you the fraction of people the model thinks is in each of the 4 states over time. And you can see that the number of people in the E, I, and R states is rising over time. And the graph all the way at right is showing you where the model thinks people are getting infected in Chicago. And you can see the growth of that red stain at the city center, indicating that model thinks that people are getting infected at higher rates in the city center. Now you should take the actual graph with a bit of a grain of salt because we're only able to fit the model to MSA level data. And so we aren't actually sure that those fine-grained neighborhood predictions are accurate. But nonetheless, it's revealing that the model thinks that the center of the city will have higher infection rates. And we'll return to that point in a bit. Now, of course, anyone can make pretty pictures. Do these actually have any correspondence to reality? And it turns out that we do fit real world case data reasonably well. You can see that, orange is reported cases, blue is model predictions. We have a reasonably good fit in Chicago and in the other 9 MSAs as well. Okay, so what can you actually do with this model? Well, you can use it to ask a whole range of questions, and we actually do this in the paper. You can assess, for example, how much of an impact does the model think social distancing actually had? What would various reopening strategies look like if we reopened restaurants, for example, to varying degrees, as opposed to, grocery stores? But today I'm going to be focusing, because this is a talk about disparities, on how the model enables you to analyze and understand socioeconomic and racial disparities in COVID cases. So we know, not from our work, from like a whole host of prior work, that socially disadvantaged groups were hit harder by COVID. You saw much higher case rates, much higher death rates. And there are many reasons for this, right? Not all of them mobility related, but some of them are mobility related. For example, if you're more likely to be an essential worker, and we know that that's correlated with socioeconomic status in the United States, then it's also more likely you'll have to go out and you're exposed to higher risk. So it's interesting to ask, therefore, if the model can learn to correctly predict these disparities using only mobility data without being told anything about the existence of these disparities. And secondly, if it can learn to make this prediction, can it understand the mechanisms via which they arise? Now, in order to do this analysis at all, we don't actually observe the movement of individual people. So what we do is we group neighborhoods by income or racial demographics, and we compare infection outcomes and mobility patterns. For example, we might compare like the richest 10% of neighborhoods in New York to the poorest 10% of neighborhoods in New York. Okay, so this slide shows that the model, in fact, does learn to predict socioeconomic and racial disparities in infections based on mobility patterns alone. The graph at the left is saying that the model is predicting higher risk for people in lower income neighborhoods. That's what the values to the right indicate, the values to the right of 1. And the graph on the right is showing you that the model predicts higher infection rates in less white neighborhoods. That's what the values to the right indicate. You can see that the socioeconomic disparities are particularly dramatic, and so that's what I'll be focusing on in the rest of the talk. But we show figures for racial disparities as well in the paper, and the results are qualitatively similar. Okay, so the model also uncovers 2 mechanisms that give rise to these disparities. And one of them, I suspect you've already guessed, is that people from lower income and less white CBGs were not able to reduce their mobility by as much, and consequently were exposed to higher risk. And this is very, consistent with what we know from prior work, right? It was harder for people to work from home, for example, because of occupational differences correlated with socioeconomic status and with race. Now, another mechanism is slightly more subtle, and it's this. It's that when folks from lower income neighborhoods went out, they went out to places, even within the same category of place, that were smaller and more crowded, and therefore more dangerous. So to be very concrete, if someone from a low income neighborhood and someone from a high income neighborhood both go to a grocery store, the person from the low income neighborhood will tend to go to a grocery store that is smaller and more crowded, and therefore more dangerous. This is very consistent with what we know, by the way, about differences in population density and how those correlate with income. People from lower income neighborhoods in the 10 cities we examine also live in denser neighborhoods. And so it's plausible that the POIs they would go out to are also denser. The SafeGraph data is very consistent with census data here. So here, this shows you another video, and you should focus on the graph in the middle. This is showing the results in Philadelphia, which is one of the places where we predict particularly large disparities. And you can see that over time, the model is predicting the highest infection rates at the city center. And when you compare that to census data, you can see that that red stain at the city center exactly coincides with the place with highest population density and lowest household income. So that's the correlation between sort of population density, income, and model predictions that I was telling you about before. A corollary to all this is that it's very important that reopening plans consider what we call disparate impact. In other words, the impact not just on the population as a whole, but also on people from socially disadvantaged groups, because infections sort of have qualitatively different dynamics due to differences in the way people live and move. And I should mention, by the way, that to their credit, policymakers really are, at least in the United States, doing this to some degree, right? They're sort of, reopening plans that can specifically consider disadvantaged populations, and that's definitely well warranted by this analysis. Okay, so a couple important caveats here. As mentioned previously, this is analysis of data from spring 2020. Zarina subsequently done a lot of work to update it on more recent time periods. The data does not cover all POIs or all people. So for example, prisoners are not well covered in this data set. Nursing homes are not well covered in this data set. We discussed some of the limitations in the data in detail, I think in like supplementary appendix 5 or something like that. The model itself is parsimonious, so it doesn't consider things like mask wearing and other aspects of transmission that are likely important in the real world. But I think an important thing to mention is that, when Zarina updated this on a more recent time period with a more sophisticated model that incorporated things like mask wearing, the high level conclusions about disparities and other things still went through. So that's reassuring. Okay, takeaways. The model was able to reasonably accurately fit daily COVID case counts. It was able to scale even to quite large networks, and it was able to capture heterogeneous risks in quite a fine-grained way. By doing these things, it was able to inform more efficient and equitable reopening strategies. To summarize the talk as a whole, as mentioned at the outset, AI and data science can certainly increase inequality, but this should not cause us to lose sight of the more optimistic sort of counterpoint to this about how they can also potentially reduce it, in this case by shedding new light on the health of historically underserved populations. Thanks very much for your attention and for the invitation to speak, and I'm happy to take any questions.
Thank you so much, Emma, for the wonderful talk. We have some time for questions. If anybody has any questions, you can either send in a question or, over chat, or you can unmute yourself directly and ask the question.
I can't see questions, so if there are questions in the chat, just let me know.
Anybody? I guess maybe I can get started, and maybe others can then chime in. I have lots of questions. So let me get started with questions about the first part of your talk, in which you were talking about arthritis and osteoporosis. What was the disease? Which it was osteoarthritis.
Yeah, osteoarthritis. Yeah.
Right. So I guess you used ALGP, your mechanism, and even after that, you do see a gap in between. The gap does not diminish completely, which would seem to, and also. When you were saying that if you use a racially diverse data set as compared to a non-diverse data set, your gap reduces much more. Both of these things, would you say that both of them point or validate the fact? I mean, not a very thorough validation, but they point to the fact that in reality, the the gap exists as a result of the combination of both the outside knees theory and the inside knees theory. It's not just the effect of just the inside knees theory which you focus on, but there are some other factors also which are attributing that additional gap, that pain gap, which is not left, which is not explained by the models that you've developed.
Yeah, it's a good question. I don't know if I'd be comfortable going quite that far. So I think it definitely validates the in the knees theory to a greater degree than previously appreciated. Sure. It's unclear to me if you could get a bigger reduction. You might be able to reduce the gap all the way if a couple things are true. If you had a larger data set, if you had better machine learning methodologies, you have better deep learning techniques, or you had a more sophisticated first author, for example, not to knock myself. Or if you were using other imaging modalities like the knee MRI. So for that reason, I would think of this as a lower bound rather than an upper bound on the amount of variance that could be explained by the knee. But yeah, I mean, it's definitely, like things like higher life stress, like we know they sort of exacerbate the effects of pain. So that's like not sure that could, I'm not ruling out the outside the knees theory as a partial.
That makes sense. And this last thing that you said, that brings me to my second question also about this part, which is, and I might be completely off here. So I mean, do you foresee any risks of using this ALGP as a mechanism for referring surgeries? Because you're using the Coos pain scores, which are self-reported, and pain is something that's very subjective. It's a subjective experience, right? I hypothesize that the pain or the discomfort that I feel could be related to my mental stress, my mental situation, and so on and so forth. And if it is the case, say that people from low-income backgrounds and racially disadvantaged backgrounds have higher levels of stress and higher levels of mental tensions, then is there a chance that that by itself would lead to higher reporting of pain? And if, for example, let's say if that's happening inside your data set, inside the Coos pain scores that they're reporting, and you train a machine learning model on this, and then based on this you refer surgeries, then maybe it's not the case that somebody should be referred a surgery, because objectively there might not be as big a problem, and the pain, the higher pain that they're reporting, there may be an element of the pain being higher, or the reported pain being higher because of these other. So I'm basically going back to the outside knees theory. So what
No, I think
potential risks of using this?
Yeah, so I think what you're hypothesizing is sort of a special case of an outside the knees theory. Indeed, the one that we speculate might be, it's like cultural differences in how different people report pain. Fine, and so yeah, I mean, that is definitely a possible outside the knees theory. Importantly, though, the model's predictive power is deriving only from the knee image, right? And so it's not, we check, for example, that like we're not just reconstructing race, for example, we're not just learning a race predictor. The model has predictive power, we explicitly check for this. We're not just reconstructing socioeconomic status. We're not just reconstructing trivial covariates like BMI. So it certainly doesn't appear that the model is just learning to predict. For example, some race groups have higher life stress. We're predicting race. We're predicting stress. This has nothing to do with the knee at all. That said, yes, of course, I think in particular, the analysis of surgery is speculative here. And I think there was a nice commentary written on our paper by an actual knee surgeon. Like, this guy is an orthopedist. He does this for a living. And he notes, as we note, that the analysis of surgery is speculative. Here are some things I would worry about. I think, doing deep learning on medical images, you do worry about things like sort of generalizability across sites, like picking up on trivial confounds and so on and so forth. We do a lot of work to try and rule that out on our data, but I think you would want to continue to do that work if you were to roll it out in a real world context. I think another thing we weren't able to do, due to just the small number of people who had received surgery in our data set, was to show that a higher algorithmic severity scores actually predict better outcomes from surgery. And I think that's a very natural follow-up that you would do, and indeed is something we're talking to folks with better data for that particular question about. You can imagine rolling this out not as a replacement for a doctor, but as a decision aid for a doctor, right? If it's like, oh, you think this guy's fine, but the model predicts he would really benefit from surgery because of heat map, you want to take a second look, and that would be an interesting direction as well, I think.
So also, have you been able to look? I mean, I'm sure you've done this, but in addition to I forgot what is the original scale that was used to measure the severity.
KLG.
KLG, right? As opposed to the factors that it uses in generating its score, what are the other things that are being used by your model in addition to them in order to generate, even though you're not generating the KLG score, you're generating the POO score. Are there other parts of the X-ray image that your model is focusing on, which KLG is not focusing on?
Yeah, I think this is a great question. So we did, there is a heat map in the paper where we sort of show a representative knee and show that it's like actually focusing on the knee as opposed to the upper thigh or something like this. And it's sort of focusing on clinically relevant pieces of the knee. We also show that the model's predictive power is not entirely explained by KLG, obviously, but it's also not explained by other clinical features that go into KLG. So it's like not something that we can easily put a name on. But I think this is another interesting direction for future work, is like you work with radiologists and have them try to articulate that inarticulable thing that, the model is. Yeah.
Okay, so I'll go back to the audience to see if they have any questions. Otherwise, anybody? Does anybody have any questions? Anyone? Nobody? Okay, maybe I'll go back to my questions. So about the COVID work, again, excellent work. It seems to me I've read a lot of. So first of all, let me ask a question that whose answer would be informative for me. I've seen a lot of models over the past year that try to fit to the data. They have their own SEIR variation, and almost all of them I've seen they fit to the data well. If they end up publishing a paper, then probably the I guess. But what they also show is that most of these SEIR based models, they have very poor forecasting ability.
Mm-hmm.
The confidence bands start widening very soon, and the right. So if that is the case, I mean, this is just a general question. I'd like to hear your opinion. How safe is it for us to use these models, even if they fit very well to existing data? How safe is it for us to use them to, for example, estimate the impact of reopening plans when they are not going to have good predictions in the future?
Yeah, I think it's a great question. So first, I don't show this because explaining out of sample validation is a pain to some audiences, but we do an out of sample validation, and we find that the model continues to predict the data reasonably well for a couple of weeks out of sample. If mobility data is known, which is an important caveat, right? But I take your larger point. I think making forecasts is challenging. I think, just because your model predicts well on sort of observed data doesn't mean that it would predict well on like counterfactuals that are well outside the space of things you considered, right? So I think that's another concern. I think though, the relevant question to me is, what are the baselines you're comparing to? And the baselines you're comparing to are often like, we're flying totally blind. We have no idea what's going on. And so I will say, without naming specific names, public health departments have been quite interested in sort of, can we take this model and like use it to improve from absolutely nothing to slightly better than absolutely nothing.
It reminds me of we have our most foremost epidemiologist here at Penn State, Matthew Ferrari.
Okay.
I was having conversations with him, and he said that we should think of these things as let's ensure that we don't let perfect come in the way of good.
Yeah,
right?
I think that's right.
Yeah.
Which is not, it's hard because it's not how you're trained to think of it as a scientist. It's like you publish it when it's perfect.
Yeah,
but
exactly.
this is like actually not. It's like, okay, great, we'll publish in 2023. Like, sure, great.
Exactly. And also, there's also this a lot of work that's happened there, on these contact matrices.
Yeah.
I would imagine that your work that you've done, this would enable you to create a more data-driven contact matrix that people have already estimated for all the 193 countries in the world. Have you considered?
Wait, what do you mean the 100? Why? How would we generalize our methodology to the other 190?
So either it's the United Nations that has funded the study, or something, some other well-known organization, but they funded studies that have been done in the past, not in response to COVID-19, where they've estimated the contact matrices, where basically what they're saying is they've divided up the population into age groups, 10 to 15, 15 to the middle age groups, older age groups, and then they consider what is there's a contact matrix that tells us what is the likelihood that people in this age group are going to interact with people in this other age group. And this is not driven by data. I mean, this is primarily driven by domain expertise. So I would imagine that your methods would give a more data-driven flavor to those contact matrices potentially.
I agree. Although I think age group context is a little, well, first we have no data outside the United States, or like maybe they have data in Canada, but it doesn't generalize well to other. But I think the other thing is, I'm not sure how great our data on age heterogeneity is, because it's CBG level. So if like old folks are moving very differently within a CBG, as is quite plausible.
Okay.
So, I mean, I think you could do something, but I just worry you'd pick up on like the difference between Florida and San Francisco, or wherever old people and young people live, as opposed to heterogeneity within, Florida or something like this.
I see. Okay. Final call, guys. Any questions? Anybody? Okay. Well, if there are no questions, thank you so much, Emma. It was, I enjoyed it a lot. I'm sure everybody else did as well. And, thank you everybody for attending. Thank you. Bye-bye.